Hello, everyone. Welcome to today's webinar, Improving Care Team Communications with Dr. Trisha Swift. My name is Lisa Johnson. I'm with Everbridge, and I'll be your moderator for today. I'd like to introduce Trisha Swift at this time. Dr. Swift is a partner at MeritLinks Healthcare Consulting, where she advises healthcare leaders and executives on topics such as the operational impact of technology, patient safety, and performance improvement. She's a doctor of nursing practice who brings more than 16 years of experience into adult and pediatric healthcare operations. Trisha enjoys contributing to the healthcare industry's transition from volume to value-based care through helping her clients transform into becoming a high-reliability organization. Welcome, Trisha.
All right. Well, good afternoon, and thanks for joining today. I'm going to speak a little bit on this pain point that we're all feeling in the healthcare setting, and that's transitions of care. I'm really going to try to zoom in on the role of communication in improving transitions of care. But first, I'm going to zoom out a little bit and talk a little bit on why transitions of care is important and how the business model of the hospital dictates and determines how well we work as a team. So for the agenda, I'm going to try to keep pretty close on these topics. Like we mentioned earlier, we'll take questions at the end, or we can take them as you come up with them by typing them in the box here. But I'm going to start with what the modern medicine rules and care models look like and how they've changed from our recent past. Talk a little bit on high reliability, and I know that's a journey that a lot of healthcare organizations are taking. It's really the right direction to go, but it's extremely difficult and has certain requirements. So I'm going to talk a little bit about that, and then we'll go into a little bit more detail about transitions of care and the impact of poor transitions and the requirements to improve them. And then I'll end by kind of putting it all together and helping us make sense of everything that we've covered today. So let's get started here. And I wanted to talk first about this patient-centered care model that came out of Dartmouth, and it's the macro-meso-microsystem patient-centered care model. And, you know, any of us that have been working in healthcare for a while knows that we've been talking about patient-centered care for years. But ironically, it wasn't until payment became more aligned with outcome-based reimbursement that organizations took the steps needed to truly flip their care model, because now it's not only what their customers expect, but it's how they get paid. So, you know, with this care model, it really speaks to the role that patients and families are not just consumers of care. They're actually members of the care team, and they are in the clinical microsystem. So under this idea, the patient now becomes the center of all the care decisions, which makes the microsystem a living and fluid environment. And the patient microsystem is considered the building block, which strengthens the foundation for all higher levels, which puts the patient as the driving force for their care rather than external forces as seen in older care models. So that is a real flip on its head, if you will, of the way that we've been functioning in healthcare for many years. It's actually an inversion of the traditional care model that allowed regulatory agencies and payers to dictate how care was delivered. But in this new modern world, those agencies are purposely designing their standards and their payment structures around what the patient's best interests are for outcomes, cost, and experience in mind. So when you look at this, it puts those agencies in the macro system on that very outer layer, and as you zoom in, you get into that real value add work that is driven by the patient but influences all those higher levels. So it's flipping the pyramid on its head. So when you try to function under a new model and you look at the world differently, you know, as that expectation becomes more commonplace, the rules change. And so this is something that many of you have probably seen before, but it's worth visiting again because now that the patient is the center, the patient is the decision maker, the rules change, and the rules are based off things like continuous healing relationships, knowledge and information that flows freely through the system where the patient owns their information, not the hospital. Safety becomes a system priority, and integration among clinicians and among the care team is a priority. And this is different from what we've seen before, where information is just a record and we base care off visits, or as some folks refer to it as volume, and where preference is given to professional hierarchical roles in the organization rather than integration and interdisciplinary care. So this just kind of shows that journey, that mental journey from the new care model to the new rules of medicine. And when you have new rules of medicine, then we have to behave differently, right? So this is where that high reliability concept comes in mind. And when I hear people talk about high reliability, many times it's inaccurately stated as a destination or a place that people want to arrive to, and it's really not that. Being highly reliable is really your attitude. It's a state of mind. It's the way your culture is. You don't go through the checklist and then become highly reliable. It's just the way the business model looks. And it has 3 requirements, which many of you on the phone I'm sure are familiar with. It's competent and engaged leaders, it's that culture of safety, and it's having robust process improvement. But when these behaviors that you see here on the first pillar, these are behaviors organizationally, and it requires the individual to behave this way, but in aggregate, you see the organization behaving in these 5 different ways that are quantifiable. And when you see these behaviors present in the organization, you're able to actually palpate and feel that acute awareness that the organization has, where they are sensitive to their operations, they understand what the front line is doing, they're preoccupied with failure, there's rigorous analysis on things that are going wrong and effort placed into preventing things from happening. They defer decisions to the expert, so the guy with the biggest title in the room doesn't necessarily know the most, and that's just the reality of the situation. So in high reliability organizations, they allow the person that knows the most to make the decisions, and you leave your title at the door. This reluctance to simplify, many times we want to correct broken processes with oversimplified answers, the top 2 being let's educate the workforce and write a policy, and then the process will be fixed. And we know after many years of research that healthcare is complex, and so we're going to refuse to accept simple answers to complex problems. And then finally, that 5th behavior relates to resiliency, and this is just the ability to bounce back when things go wrong, and it doesn't keep you down for too long. So I will put all this together for you, but I wanted to just touch on the care model expectations, how when the model changes, the rules of the game change to meet those expectations. And when you start playing by a new set of rules, your behavior changes. And that's really that psychological and mental journey that organizations take into adopting this new attitude regarding high reliability. And when you have a new attitude about your world and about your work and about your team, the processes start to change. And this is where we start to see safer, more efficient workflows, better experience, better outcomes. And there's some key components there that are required to allow those things to happen. But really what we're getting here to is, there's a toolbox for success that helps all organizations get through the process of becoming highly reliable, But more importantly, we're interested in what's in the toolbox, and that's what we're going to talk about here a little bit more detail, is specifically what's in the toolbox that's going to help organizations go through this process. So now I'm going to switch gears just a bit and talk about the role of care team communication. And I can't talk about communication before I talk about the reason why communication is so important. And that's really because it's the #1 cause of sentinel events in our country. I'm sure many of you saw this study come out last year through the CDC and the BMJ that reanalyzed medical errors and their impact on causes of death in the United States. And while we don't include medical errors on the CDC's top 10 list of deaths, if it were, it would be 3rd on the list of most common deaths in the United States, which is astonishing because if you think about it, these are only medical errors that are reported and quantified. And in my experience, most medical errors are not reported and hard to quantify. So I shudder to think of where this would be on the list if we were able to capture all medical errors. Other than its impact on human life, we're well aware that the cost of medical errors is astronomical. There's citations of various numbers. This one that I pulled is $17 billion of avoidable costs a year. And in most cases, it all comes back to the way that we communicate with each other or the way that we don't communicate with each other. And I really like this quote here that I found through IHI, and it says that extensive research has shown no matter how knowledgeable you might be, if you're not able to do open and effective communication with your patient, you're of no help at all. And right, wrong, or indifferent, I'm sure we all have a clinician in mind that is brilliant in their approach to medicine, but lacks communication skills, which only limits their value to themselves in many instances. So a little more stats on the role of communication. As we know, it's an essential part of the care team, and particularly in team-based collaboration models. So in a patient-centered care model, communication is key if the patient is in the center of all that we do. And when we're not communicating effectively, there's a plethora of literature that shows that critical information is missing, information is misinterpreted, orders are unclear, and most importantly, status changes are overlooked by the care team because we're not communicating clearly and accurately and timely. Again, if it were to appear, medical errors were to appear on the top 10 causes of death, it would rank 3rd. I think it's notable to say that what that means is it's ranking ahead of accidents, diabetes, Alzheimer's, AIDS, breast cancer, and gunshot wounds. Communication failures continue to be the leading root cause of sentinel events reported to the Joint Commission for the last 11 years. And I continue to go back to the report from the Joint Commission each year waiting for communication to lose its ranking as the #1 reason, but it's still there. It's the #1 root cause for medication errors and delays in treatment, which delays in treatment is a catch-all for many, many types of errors. And it's the #2 root cause for operative and post-operative events and falls that result in death. So we've kind of understood the landscape of where healthcare organizations are trying to get in terms of high reliability. We've touched on the role that medical errors play. And now I want to talk about one of the most complex processes in the healthcare system, and that's transitions of care. And so when we talk about transitions of care, I think it begs a small understanding of what that means, and it's really the handoff between phases of care, both internally and then into different phases of care that the patient experiences, that we at times and historically have placed not as much effort into as maybe we should have, because again, if we're looking at it from the patient's perspective, the fact that they're in the clinic, the hospital, or receiving home care makes no difference to them. It's still the longitudinal journey of their healthcare experience. And so this particular slide just very simply touches on what a series of events could look like for a patient that is seen in the primary care clinic and receives a diagnosis for pneumonia that requires hospital admission. It's very common. We're coming up on that season. Hospital admission happens, and for whatever reason, dehydration or just weakness, the patient develops a low blood pressure. And of course, that low blood pressure patient doesn't see their own risks in getting up alone, so they do. They get up to go to the bathroom by themselves, get dizzy, they fall, they fracture their hip. This is not a terribly uncommon scenario. It happens all the time. The patient requires a skilled nursing rehab stent after discharge for rehabilitation from that broken hip, and then they go home with a visiting nurse. So this sort of longitudinal journey from the patient has several different handoffs, several different transitions of care that require a lot of communication and transmittal of information to ensure that the patient is adequately prepared to either care for themselves or their care providers are prepared to assist them. One statistic that I found quite interesting is in the hospital alone, patients encounter 18 to 26 healthcare professionals. This is for a general medicine admission. When they're admitted for a surgical or procedural nature, this number doubles because they're going from a little bit more phases of care within the healthcare setting. So the role of communication cannot be understated, just given the fact that there's so many different people caring for this one patient, hopefully with all the same goals in mind. So when we look at poor transitions of care and what sort of impact that has, there's several truths to be discussed. Ineffective care transitions obviously can lead to medical errors just due to the breakdown of communication and information, but the literature shows us that ineffective transitions of care are directly correlated with high readmission rates. Oftentimes we look at length of stay as a correlator to readmission rates. We should also be looking at transitions of care as a correlation of readmission rates. And obviously, extra consumption of healthcare services results in extra costs. There have been studies, one notably out a little over 10 years ago was estimated that 80% of serious medical errors involved miscommunication during the handoff between medical providers. So apologies to any physicians on the line today, but providers, physicians are one of the worst disciplines for handoff in the hospital. They do not do that very well in most cases. And we can see that from provider to provider or consultant to attending or any other combination of handoff can really impact how well the patient's outcomes occur. Problematic transitions occur in every type of healthcare setting, but it's especially complex and especially problematic when patients leave the hospital and go to the post-acute care setting, whether that's at home or it's in a post-acute care facility. So this is a particularly error-prone and problematic process that as an industry, we haven't really done a good job at securing that transition of care, and now is the time. So again, this isn't new information, I'm sure, but CMS has taken notice of the transitions of care issue in our industry. And if you're not aware, it is going to be part of the value-based purchasing program, and is the performance period for measuring transitions of care is soon approaching us. And it will be measured by the way patients perceive their transitions of care, at least initially, as further quantified outcomes are defined for that. So if you're not working on this now, you should be, because it's going to be part of your performance portfolio very soon. So creating highly reliable transitions of care, I've pulled out 3 issues that I find to be the most prominent in transitions of care, and so we'll start with the role of patient education. So if any of you have been a patient before, you can attest to this, but given the fact that medical patients encounter 25 people in their inpatient stay, they often receive conflicting recommendations, confusing medication regimens, and unclear instructions about what they're supposed to do when they leave the hospital. This is a cause of many different things, but 2 big ones here are related to the fact that they're often excluded from the discharge planning process, their transition process. I'm not sure why. We just don't routinely include the patient as part of the patient care team, and we should. The other thing to just keep in mind is patients often lack sufficient understanding of their medical conditions, the medications they're on, or the importance of adhering to the care plan that's been prescribed for them. We all know about those patients that know they take a blue pill and 2 white pills and a pink pill, and they don't know what they're for, and they don't know the names of them. And so, that's just one example. But, knowledge is power, and if we can inform our patients slowly and surely over time, we can help them become empowered over their own health. Issue number 2 is about accountability, and this really speaks to the role of the provider in creating highly reliable transitions of care. And so in many cases, not all cases, but in many cases, there's no physician or clinical provider that really assumes ultimate responsibility that the patient's healthcare is coordinated across various settings. Now, there are a lot of operational challenges on why that is so. And, we take that onus as healthcare providers to figure out how that looks and how that feels. But, if you look at the graphic over here of doctor's orders, I'm sure many of you see orders like this all the time. So discharge the patient when so-and-so and so-and-so and so-and-so sign off. That really needs to be a conversation among the provider team, and not passing the buck, if you will, for so-and-so to sign off and then they can go home. Perhaps a conversation is warranted between consultants on a case so that they are all aware of the discharge plan and the barriers to being successful with that. Follow up with the PCP in 2 weeks is order number 2. What we find is that primary care providers are often not even identified by name in the discharge care plan. A lot of times patients don't have a primary care provider, but if we know that follow-up care is important to their success of taking care of themselves and preventing them from coming back to the hospital, then we should elevate the importance of coordinating that into the discharge care plan. Also, continue with home meds, new scripts on the chart. Typically, at the time of discharge is when medication education takes place. It's the worst time for education to take place as the patient's preparing to leave. High-performing organizations deploy things such as pharmacists coming to the bedside to teach on medications early on in the stay, so it's not rushed and shallow at the time of discharge. And so this accountability of roles and responsibilities is a high-ranking issue in our transition of care processes. Issue number 3, of course, we're going to talk about communication. So in general, and I put myself in this bucket when I say these things is, in general, care providers do not effectively or completely communicate important information to themselves, to their patient, or to those taking care of the patient. So the question is why? You know, there could probably be a longer list than this, but the reasons why we don't do a good job at this is we have expectations that are very different among the care team, and we don't understand the expectations of each other. We're a very autonomous group of folks as clinicians, and we tend to assimilate our expectations to everyone else, and that's not always the case. Sometimes culture gets in the way, where it doesn't promote successful handoff because there's not respect for that process, and there's not mutual respect among the team members. We're often rushed. There's not enough time to do adequate handoff, and many times there's lack of standardized communication procedures and or tools to facilitate standardized communication. So a lot of these things can be achieved electronically, particularly with communication tools, and this is one of those times where technology can help the process and create a more efficient process. My little cartoon here is just speaking to that role of the culture and the lack of respect among the team. Many times I've heard this quote where, you know, we don't have time for rounds, we don't have time to do a full S-bar for handoff, I have work to do, I have patients to see. And this is part of the problem. We need all care team members to find equal importance and place equal attention into the role of communication in our day-to-day operations. So I won't go through everything on here, but I did propose some potential solutions and tools that are rising to the top of the list in priority for beginning to chip away at this complex issue of improving transitions of care. The first would be to deploy risk assessments for readmission, and really looking at who the patient is and understanding their barriers and treating each one uniquely. And this takes into account things such as literacy levels, how they look at themselves, and whether they have multiple conditions to manage. Patient education, as I mentioned earlier, it is super important. We all have always said discharge planning begins on admission, but what does that mean, and how do we do it? Okay, we agree it begins on admission, but how and what do we do? And really talking about that role of actively teaching the patients early on. So when discharge comes, we're not bombarding the patient with a packet of information and medication sheets and all this stuff. They absorb nothing at that point. Team-based care, the role of accountability, the effectiveness of multidisciplinary rounds, discharge planning, and discussing barriers of discharge are super important, not only for building the right culture, but also for involving the patient. And then finally, the role of communication. Many places are doing a post-discharge phone call, just checking in. This is a really good time to see if they've filled their prescriptions they were supposed to. You know, there's often a lag time after discharge and filling the prescriptions, just because of the whole activity of getting home. And so the discharge phone calls are a really good time to make sure that that happens. And also this idea of using real-time communication within the hospital setting, and even from the home setting to the primary care provider, regarding all of those things that put our patients at risk, like changes of condition or new social barriers or their recovery progress, or even if they're able to take care of themselves, change their dressings, administer injections, so on and so forth. And so as we are entering into this paradigm of clinically integrated networks and multiple phases of care functioning on similar platforms, both post-acute and acute, and satellite locations, we have this opportunity to deploy real-time communication from all phases of care on one single platform. And if we could do that and break through that barrier of timely communication, and across disciplines and across care teams, it would really help put that patient first and identify their risk factors before it becomes another hospital admission or even a decompensation in their condition. So bringing this all back to what we talked about in the beginning, communication is key to high reliability. So high reliability, those behaviors that I spoke of earlier are really divided into two categories. And one is being proactive, and the other is bouncing back and containing things. So when you talk about the role of communication and the concept of preoccupation with failure, knowing about near misses, knowing about things that are happening or that almost happen, or safety concerns, requires real-time communication. And so you cannot be preoccupied with failure and preoccupied with preventing failure if you don't have that in place. Reluctance to simplify, again, healthcare is complex. The answers aren't so simple. However, simplifying a process could be the answer. All of that requires rigorous analysis of processes, digging into root cause, having focus groups, again, contingent upon team-based care and communication, sensitivity to operations, the third one here about being proactive. These are your Gemba walks. These are talking to your staff, listening to their concerns, and knowing that an accident is most often not the result of a person. It's a result of the system and how that person functions within the system. But truly understanding where those breakdowns are requires that leaders and executives get out of the office and go talk to the people, because that's where your answers are. The two behaviors about bouncing back, commitment to resilience and deferring decisions to the expert, again, if we're able to identify and control and recover from errors, we have to have a team approach in doing that. We have to have recovery efforts in doing that. And clearly, deferring your decision to the expert, this is, your timeouts. This is where attending providers rely on consultants and, case managers, talk to nurses, and everyone's asking each other their expert opinion on the domains for which they own. So the consensus can be gained by taking all perspectives into consideration on what's best for that patient. It's no longer the captain of the ship philosophy, if you will, regarding planning our patient's care plan. So my last slide here is about putting all of this together, and I'm going to go back to the oldest quality improvement model out there, probably from Dona BDN, comes from 1966, and it's regarding the structure, process, outcomes model. So if we look at the high reliability journey and how that applies to transitions of care, creating the right structure, creating the ability to identify risks is the first step. We cannot do the right things if we don't have the structure and the ability to do them. And so when we look at structural requirements, we're looking at the culture. We're looking at the way the employees are empowered. We're looking into our toolbox. Do we have the right tools to do the job? And we're looking at whether we really do put our patients first or whether it's a marketing gimmick. And following the required behaviors that prove and demonstrate our patients truly are first. And once those structural components are in place, then we know what to do. And we can deploy the right processes and share information. We can make real-time decisions and not decisions based off of errors. We seamlessly communicate across the team. We're behaving like a high reliability organization. And once we're able to know what to do, then we can do. And this is where you see the outcomes that we want to see. So we can't make goals for achieving outcomes without first putting the structure that allows the process to happen for the outcomes to be achieved. And those outcomes are an error-free practice environment, or harm-free, as some people say, optimal experience, being resilient as an organization. So when there is an error or something does go wrong, we quickly correct course and bounce back. And then lastly is this exceptionally safe and high-quality patient care, which is the ultimate outcome of the triple aim that we've all been trying to deploy over the last few years. So with that, putting this all together will ideally achieve that high reliability and zero harm. And guys, this is a marathon. It's not a race. It requires training and commitment. And it's been my pleasure today to talk to you about this. And I'm going to wrap up and hand it off to Lisa.
Thank you so much, Dr. Swift. That was a great session. We really appreciate all of your information. It's so obvious that you're really passionate about this and that there's this very real path forward that clinicians can go on and see significant improvements in their patients' lives and ultimately in clinical staff's lives as well, making everything work a little better. Should be switching back. So we're going to go into the question segment now. If you do have any questions, please go ahead and ask them. We've already received a couple. I also want to take this time to let you guys know that Trisha is doing another webinar for us on October 25th at 2 p.m., same time as right now, 2 p.m. Eastern Time, and she's going to be going over the specific impacts of patient outcome and patient satisfaction, as well as the cost savings that you can have while you're implementing these quality measures. So that'll be very effective if you need to convince somebody with a budget that this is the right thing to do. She's going to give you those tools that you can present to the decision makers. Okay. Along with this, so how does Everbridge fit into all of this? Well, we do have a product called Care Converge, and it's something where we put the patient at the hub, and clinicians come in and sort of come all around the patient to help manage their care. So one of the things that Trisha had brought up is that different consultants coming in on a patient case might not necessarily talk to each other. By using the Care Converge platform, all of those people are in the same conversation the entire time. And that helps significantly in communication flow. You can also bring in other types of reports such as a lab report, MRI screens, blood work, all of that kind of stuff, pharmacy. If you're passing off to another facility, if the patient is transferring locations, either in hospital from ED to an inpatient floor or discharged and even going home. So coming into patient-centered care, like that is exactly what the Care Converge process does, and in fact we're already in 23% of all hospital beds in the U.S. We already cover that. Because of the CMS emergency preparedness guidelines, which are coming into place in just about a month, every single person in a clinical situation who is in a hospital that has Everbridge already is in the system. So it's literally just a matter of tweaking a couple of things on the software platform to introduce clinical care. From here, with Care Converge, we cover many different areas: care team management, EHR integration, telemedicine, secure communication. We are HIPAA, and everything works together in a seamless way. All right, I'm going to go into the first question. Do you have any suggestions on how to include the patient in the communication workflow, specifically if using a clinical communication platform?
I do, and obviously your patient's not going to have access to the platform, as it's a platform of the employer's care team. But there's nothing to prevent the platform from not being utilized during multidisciplinary rounds, and having some of the patient's input and feedback from the discussion that happens during those rounds put back into the communication tools, so those that are not present can still take part of the benefit of hearing the patient's perspective, and particularly what they're worried about regarding getting things set up for the post-acute phase of care, such as supplies, caregivers, and medication regimens.
Thank you. And then So we were talking a lot about value-based care and moving to that platform. When do you need to begin to prepare for that, and who are the people that you maybe you haven't thought of them, but who do you need to pull in to sort of an initial group of people to take the hospital or facility through that process?
That's a loaded question that I probably can't fully give justice to on this call, but please feel free to contact me after the webinar. What I would suggest is doing a baseline analysis of where you sit today in terms of what's being measured for value. And in that exercise, it should point you in some directions of at least low-hanging fruit for folks to involve. But the journey to value-based care, the journey to high reliability involves every single person. It's really a grassroots effort. And just like we turn the pyramid upside down to put the patient in the driver's seat, same with high reliability. It starts at ground level to support all the higher objectives and strategies that the executives anticipate coming from it. And I have lots of ideas and strategies on that I'd be happy to speak with folks about after this, but it's a huge commitment, and we must be ready to take it on. It'll involve a lot of work.
I do think this is going to be similar to really any process, ICD, all of those coming in, where it's going to be a long road of 0 to 10 years to really get everybody up to the level that the originators of value-based care envisioned.
Yeah, for sure. It's a business model. It's not a project. It's not an initiative. It's the way that you choose to do business going forward. So it's in every thread of the organizational framework.
Yeah, I 100% agree. Thank you so much for coming today. So with that, we're going to wrap up this session today. If you do have any follow-up questions, my email is right at the bottom there, lisa.johnston@everbridge.com. I will make sure that the questions get over to Dr. Swift and we get them answered for you. If anyone has any questions at all, please feel free to reach out to me. I'll do my best to answer them. And Trisha, we very much look forward to having you coming back on October 25th at 2 p.m. ET to continue this conversation and talk more about what you were just talking about, the business plan and how this makes sense for healthcare facilities to convert over to value-based care. Thank you so much.
Yes, thank you for the opportunity. It's been my pleasure. Appreciate it.